Welcome everyone today. This is the SNF Train the Trainer sepsis screening session. So just to make sure everyone understands, you are being, more than likely, you have gone through the sepsis training with Pat or one of our hospital partners, the 6-session sepsis screening training. And then this is actually to train you to be a trainer to implement that program. So just wanted to be clear. I think we put that out there pretty clearly, but didn't want anyone to think that this was the hybrid, short, brief sepsis training. This is to train you to be a trainer. So I just have a few housekeeping things today, so we'll go over them quickly and then turn it over to Pat. Just wanted to let everyone know that this is a training provided through Superior Health Quality Alliance, and MPRO is a member organization of that. I'm Barb Link. I'm one of the senior quality consultants here with Superior Health. That organization, Superior Health, was formed in 2018, and it's made up of the 8 healthcare organizations across 6 states represented here on the slide that you're seeing. It's working to achieve broad CMS goals, and our goal is to collaborate to improve the quality of health and healthcare for consumers, patients, clinicians, organizations, and communities that we serve. So I would just like to welcome you to the SNF Sepsis Train the Trainer course. Just a few things, please, when Pat is speaking, if you could make sure that your mute button is turned off. It's up on the right-hand corner of your panel screen there. You just click on it. And if you do have something that you really would like to ask a question, you can either chat it in or you can unmute yourself, and we'll try and answer that question for you. But as Pat's providing her training today, please keep it on mute so we limit background noise. If you have called in over the phone, you need to press *6 or the mute button on your phone. And always remember to do that again to unmute yourself so we can hear you. Always remember, don't disclose any personal health information during the discussion. If you're having any trouble with Zoom, your audio or your visual, Jessica Newsom is our tech person today. And if you could just chat into her, she'll try her best to help you out. If you have any other questions or comments, please chat them in so everyone can see them and we can address your questions or comments along the way. We always want to foster a positive learning environment. So please remember that as you ask your questions and make your comments. And this session will be recorded for future use, and it'll be posted to the Superior Health YouTube channel. So please realize that as well. So without further ado, I'm going to turn it over to Pat. Many of you know her well. She is been our trainer for our sepsis and infection control program for quite a while now and has helped us with training for hospitals, SNF, and home health agencies. Today, she will be providing the overview and training on our SNF Train the Trainer program. And she is currently the Quality and Patient Safety Program Manager at Michigan Medicine University Hospital and Frankel Cardiovascular Clinic. So I will turn it over to you, Pat. Thank you very much.
Hi, Barb. Thanks a bunch. And we'll get right into it. So again, I just want to emphasize that the foundation of this program was a partnership between health systems and skilled nursing facilities. And that's with the trainer being from, or the facilitator of the sessions being from the healthcare organization, the hospital. But the information and the context of this, you know, could be run if you're a skilled nursing facility with multiple facilities. You could run this, one of the facilities take the lead and run this program with the other facilities. So it has many ways to apply it, but just wanted to make sure if, as we talk about the program objectives and how it's organized, that was its original intent. And so we're training today to help you to be able to provide this program either in your facility or with other facilities. Hopefully, I know Barb sent out that a link to our guide, right, the toolkit, and in the toolkit is everything you need to put on this program. And we're not going to go into each PowerPoint, and I'm not going to educate you on what is sepsis. We'll talk about the screening tool, but the what is sepsis, and as well as what's the best practices for preventing CLABSI and stuff. We're not going to get into that content. Hopefully you reviewed that content, and if you have questions about the content, then I'd be happy to answer those or clarify those, but we only have 2 hours in that. This program is, you know, each session is 2 hours. And so there's no way we can get to that level of detail. Okay, so go ahead to the next slide.
And Pat, just quickly, just so you know, we did send that link out with the invitation, but the toolkit, Jessica just put that link into chat. So if people want to copy that toolkit link as well, it's in the chat now too.
Great. So as Barb had said, what we're going to review today are the objectives of the program, talk about the different facility expectations, and so this would be the skilled nursing facility expectations. What do the meetings look like? And now they would be virtual. And then setting expectations. That's one of the unique features of the program is giving them homework and having them agree to the different components of the facility expectations through a participation agreement. And then what kind of prep would you need to do for each meeting? And then we'll do a broad review of the components of the toolkit and then leave time for discussion and questions. And so feel free to write questions in the chat. I have that open so I can monitor it, and then you can unmute yourself and ask a question as well. All right, next slide. So here's the toolkit that you have the link now, and you should have gotten when you got this invitation. It's divided into just an overview and then all of the training materials, and then different tools that are used within the training materials and to use in your organization, and then resources. So we'll walk through this, but the beauty of this toolkit is you don't have to invent anything. Agendas are there, and the PowerPoints and education for each session. And so we've tried to make it pretty turnkey so that you can easily adopt it. So go ahead to the next slide, Barb. So in each of the meetings, the sessions that you have with the people that you're training and working with, you're going to review the program objectives, and those are to develop and implement an early sepsis recognition and treatment program, to standardize processes for treatment of patients with sepsis, to standardize processes for infection prevention of pneumonia, CAUTI, and CLABSI, with goals of decreasing the rate of transfer to a higher level facility and to decrease sepsis mortality rates. So next slide. So the program are, I think it's 5 sessions or 6 sessions. It's been a while. But I think it's 5 sessions, and they were meant to be face-to-face, 1-hour sessions, the first session being an hour and a half, and then the rest being 1 hour. But this will have to be adapted based on the current situation we're in. But a Zoom meeting like this would work okay. It's not the same as face-to-face, but it's what we got to do, which is fine. And through the program, you're going to walk through an action plan to implement sepsis, early recognition and management that also focuses on infection prevention. One of the things that if you're a hospital partnering with a number of skilled nursing facilities, as the facilitator of this program, we had 2 site-specific coaching calls over the first 3 months to be able to provide some individualized support. And so that was helpful for a lot of organizations. And then the part of the program is to provide the training and educational materials so that you don't have to reinvent the wheel. And then to talk about what are some of the process and outcome measures that we're going to use to evaluate the success of the program. So next slide. So facilities expectations, and this is important. This is part of the first meeting agenda. It's also part of the participation agreement that, that we'll see in a few minutes. Each facility is expected to have a team identified to do this work. And at a minimum, it should include the medical director, the director of nursing, and an infection prevention nurse. But it can include any of the other staff that you would normally have as you put in a new process in your facility. And that's important because this can't just be the person that's attending these meetings having to do all the work, because you need physician staff and providers to buy in and support this work, and as well as it has to coincide with your focuses on infection prevention. So it's important to have a facility-based team that's doing this work. And the team will work through that action plan, and the action plan is meant to be a working document where your team at your facility would, put in due dates and when you're going to complete what, et cetera, so that you can stay on top and on task. The expectation is that you would implement a sepsis screening process, and that you would also implement an early management of sepsis process in your facility, that you would educate staff on sepsis screening and management processes, and it would not be just a one-time education, that this would be incorporated into your onboarding process so that it would continue to live on and just become one of the things that you do at your organization. And then as a facility, you would be expected to assess your current infection prevention practices related to pneumonia, UTI and CAUTI and CLABSI, and identify where there are gaps and define an intervention to approve and close that gap, as well as collect process data and outcome data, and that's where MPRO has been very helpful in doing that as well. Okay, next slide. So one of the things that we did, the first step in the process is to get a participation agreement, and I think that that's somewhere on the next slide, or once the facility has agreed to participate, then we send them a sepsis facility readiness evaluation, just to understand. These questions are thoughtful questions, identifying potential gaps or barriers to being able to effectively implement a sepsis early identification and management sepsis program. So questions like, do you currently, what's your current state? Do you screen for sepsis, and if so, when? And what is your current process for preventing and identifying and treating sepsis? What's your nurse-patient ratio? What kind of staff do you have on? If you only have one RN for 20 patients, it's going to be very difficult for that RN to screen everyone for sepsis. So those are some of the questions and why we're asking those questions. And do you have access to IV fluid? Do you have access to broad spectrum IV antibiotics? So those are kind of will let you know what kind of things you need to have in place to be successful. Go ahead, next slide. So this is the agenda for the first meeting. So I guess I don't have a participation agreement, but we can bring it up at the end if people have any questions about it. It's part of the toolkit. And again, it just outlines the facility expectations, and it has the administrator of the facility sign off on it so that they will support the work that it would take to be involved in this program. So the first meeting, here's the agenda. And like I said, the first meeting is 90 minutes, and then the rest are just 1 hour. And, well, and in fact, you could do it in an hour if you wanted, because this isn't a 1 hour agenda. So the goals for this meeting is to introduce the facilities to the program, assess their current knowledge on sepsis, review the sepsis action plan, and then define the first homework expectations, and then to review what the purpose and expectations are for the coaching call. And so what you hope people walk away from this meeting with, understanding the expectations of the program, that they have now a basic knowledge of sepsis and sepsis screening, and they understand what's expected of them before the next steps. So you can see the agendas are pretty similar, except after agenda 1, instead of assessing your knowledge, it'll be review of the homework. So it's a round robin where we're going to review the homework. Then there's always a learning session. And so new content is shared. And then it's a review of the action plan, and then a definition of what's the homework, what are the next steps. So that's a typical agenda. So go ahead to the next slide. So in the introductions, we have people share, and so even in a virtual environment, you can have each facility share their name, their role, and what work they've done so far on sepsis. Go ahead. So these are all parts of the first meeting. And then we have them after we had them complete this when they were coming into the room. So here, this would be something that we would need to send out if you're doing it virtually, and have them completed and send it back in. But this tool is a pre-test, post-test. So as you're providing sepsis education at your facility, this could be used as a pre-test, post-test to see whether or not knowledge was gained. Next slide. So then what's reviewed at this first meeting is a detail of what is sepsis, why should we worry about sepsis, and what are how do you early identify it, and what are the treatment strategies. And so it's a lot of content, but it's a good overview. And then we introduce the screening tool. And this was developed similar to the hospital screening processes, and a lot of the organizations that have gone through this program have put this screening into their workflow in their electronic medical record. And so the screening should be performed, and this is an expectation, at admission and every shift for at least 7 days, or if they're on antibiotics throughout the course of them receiving antibiotics. Now, a lot of facilities chose to just do it every shift, every day. But one of the things that you would need to do is you need vital signs to be able to complete this, because you need a temperature and a heart rate and a respiratory rate. And so in the minimum of the first 7 days, you should be taking vital signs every shift. Beyond that, you might not. And so that's something to consider. But this would be the minimum that you would do it upon admission in every shift for at least 7 days, and if there's a condition change, and we'll talk more about that. So I will spend a few minutes going over the screening tool, so go on to the next slide. The first step in the screening tool is, does this patient have signs of systemic inflammatory response syndrome? So temperature, heart rate, respiratory rate, white count. And then blood glucose is also something to look for as a trigger. And if I don't have 2 of these, then I am negative and the screening is done. But if I've checked 2, then I should move on to section 2. And one of the tricks, or go ahead back, Barb, one of the things that we recommended to people on the first step, go back, is if I had either a temperature, heart rate, respiratory rate, or a white count that met this criteria, then I should check a glucose to see if I trigger that second SIRS. But if I don't have a temperature, a heart rate greater than 90, a respiratory rate greater than 20, and I don't have a white count available because it's greater than 24 hours old, then I would consider it negative and I wouldn't check a glucose because you need 2 to move on. So if I have 2 SIRS, then I move on to the second section, and that's on the next slide, and it's, does this patient have a known or suspected infection? And so are they on antibiotic therapy? So did they come from the hospital being treated for pneumonia and they still have a couple more doses of antibiotics? Or do we suspect an infection as the clinician at the bedside? Did they spike a fever last night and now they're coughing up green stuff, et cetera? Then you would check yes for that. So if I don't check yes to either of these, then I have a negative sepsis screen and I'm done. But if I do check yes, then I move on and need to look for organ dysfunction. So if I have 2 or more SIRS and a known or suspected infection, it's important that I make some changes in my monitoring of this patient, because this patient has sepsis and is at risk for progressing. And so I would want to monitor my vital signs more frequently. I would want to place the resident on intake and output, or at least on output, so that I could monitor and record the urine output, and potentially obtain a lactic acid just to see if there's any metabolic organ dysfunction going on. So we move on to the third step, only if I have 2 or more SIRS and I have a known or suspected infection. Now I want to look for any new organ dysfunction in an organ system distant from the site of the infection. And so here the top 4 are ones that anyone can do at your facility. Doesn't require extra testing, extra monitoring. It's looking for organ dysfunction in the respiratory, cardiovascular, renal, and central nervous system. And so I'm looking for a O2 sat of less than 90 or increasing O2 requirements, blood pressure less than 90 systolic, or a 40 millimeter of mercury drop from their baseline, urine output, which is why it's important if I have 2 SIRS and infection to monitor the urine output. Have I had less than 0.5 milliliter per kilogram over the last 8 hours? And mental status changes. If I answer yes to any of those, now I screen positive for severe sepsis. So I have 2 SIRS, a known or suspected infection, and new organ dysfunction. Now you can do, in the hospital we use labs, but you don't want to use lab results that are older than 24 hours. So those are the criteria: the platelet, the INR, the bili, and then the serum lactate. But if you don't have newer labs within the last 24 hours, I would not recommend using those labs. Also, I wouldn't recommend necessarily getting all of those labs. That would be up to the physician or provider, and you'll be calling them because now they've screened positive for severe sepsis. So if they screen positive for severe sepsis, meaning they have 2 or more SIRS, a known or suspected infection, and 1 or more organ dysfunctions, it's important to review their advance directives to understand whether or not they want aggressive treatment or to go back to the hospital. And if there isn't an advance directive, you know, being able to reach out to the family, and then call the physician and follow the SBAR on the next slide. And this is important. This SBAR is important because it succinctly shares your concerns and what you need from the person on the other end of the phone. And we heard anecdotally from physicians from facilities that had this education and put in the screening process that they appreciated the call when someone screened positive for severe sepsis that was succinct and in this format, and it gave them more confidence that the facility can handle getting extra labs, providing some additional interventions, because they were very clear on what they found and what was needed. So calling the provider, you tell the physician or NP or PA that the resident has screened positive for severe sepsis. In the background, you describe how they screened positive, what were their SIRS, infection and organ dysfunction, and then other assessment data, vital signs, pulse ox, and any additional information. And then the most important piece is if a patient is screened positive for severe sepsis, the evidence-based recommendations are to get 2 sets of blood cultures before starting broad-spectrum antibiotics, get a CBC, get a lactic acid, and get IV antibiotics started. And these are broad-spectrum antibiotics. The systolic blood pressure, if it is less than 90 or 40 millimeter mercury drop from their baseline, then I would need an order, Dr. So-and-so, to give a fluid bolus of 30 milliliters per kilogram over an hour. And then if the patient's blood pressure is still low, what would you like me to do? I mean, I can call you back. Would we want to? The recommendation is that if your blood pressure is still low, your patient needs to go to the hospital. So next slide. So we put the bundle for an extended care facility or a skilled nursing facility just into one page here. And so if a patient screens positive for severe sepsis, these are the things that you need to do. And you can see what's included here also is an increased frequency in vital signs as well as monitoring I&O. And so I think that that's an important piece of this. One of the other items that when someone has a change in condition or there's a trigger from the stop and watch, the nurse should screen the patient for severe sepsis because the changes that might have occurred could be related to sepsis. Okay, next slide. And if your facility has not put in stop and watch, I think it's a great tool. So it helps link the CNAs to what to watch for in the patient, and then what to tell the nurse. You know, when to heighten and say something's different. So if any of these, and it's in the acronym stop and watch, and if any of these are occurring, they could mean sepsis. And so that's why if this gets triggered and the patient, the CNA is coming to the nurse and saying, here, they triggered stop and watch because they were eating less or they drank less or they were agitated, those would be all good reasons to want to screen them for sepsis. So go ahead. So I just wanted to spend a few minutes going through the screening process since that's the essence of of the program is to put that into a process so it's done on a routine basis, because if you don't identify sepsis, then you can't treat it. This is the overall action plan that I referenced, and this should drive the and be used by the facility to guide their work. So you can see the first step is get a team together. Okay, so who, by when, and what's the status? So this is supposed to be a working document for the teams to be, attendees to be able to use to know where they are in the process. Second step is to make sure you have medical staff support. And third is to develop the screening tool and process and define the frequency. We've defined the minimum frequency and we've developed the tool for you, but now you have to work it into your care processes. So do you put it in the EMR? How or where, if you're going to use paper, where is that paper going to sit? Who's going to do it? The recommendation is that the bedside nurse does it versus maybe the infection prevention nurse screening everyone. It works best if closest to the patient with the clinical knowledge is doing the screening. The fourth step is to define the content for the staff education, who's going to provide it, and an implementation plan for when you'll go live with the program. And so the PowerPoints that are shared with you have all the content you would need to be able to take and use to educate your staff. We also have developed voiceover presentations for both nurses and CNAs on the sepsis, as well as, and Barb, correct me if I'm wrong, we developed them also for the pneumonia, CLABSI, and CAUTI, right?
Yep, we still have them. Yeah. Mm-hmm.
Yep, so those are available in the toolkit. So for example, if you don't want to teach face-to-face with your staff, you can give them this link to the video and you could supplement it with, okay, our process here will be, but here's the content. So again, we're trying to make it easy for you guys to put this in place. The fifth step in the action plan is to develop patient and family education tools and processes, and we share tools. Those are available in the toolkit, but you would have to define the process to get that information to your patient and families. The sixth step is to audit your screening process and then to collect process data as well as potential outcome data. And then the seventh step in the action plan is assessing current state related to infection prevention practices for pneumonia, UTI, and CLABSI, and then identifying an opportunity where there might have been a gap between current performance and what the evidence says, and then trying to close that gap. So go ahead to the next slide. So in each session, you will get presentation slides that have the program objectives and expectations, and all but the first meeting. The second agenda item is a round robin where the facilities share the homework that was assigned at the prior meeting, discuss issues and barriers, and then they can brainstorm solutions with the group. So maybe one group, oh, I had that barrier too, and this is what we did. So it becomes a great sharing dialogue. And at that first meeting, we use that time to have them introduce themselves. And then the content for the meeting. In the first meeting, you saw that the content was what is sepsis and how do we manage it, and then reviewing the screening tool, and then, but each meeting has a different content, and then we'll review homework, and then signing up for coaching calls. Next slide. So the round robin, the purpose of this is so that the different facilities can share the results of the homework. As you set expectations that the homework needs to be completed between meetings, and then they know that they have to come and share it, they're more likely to do it unless there are untoward circumstances where they couldn't complete it. You can choose to do a meeting every other month or a meeting each month. If you think that people need more time in between, then you can do an every other month, and that gives them, you know, 7 weeks to do something versus 3 weeks. So that's up to you. The round robin also allows the facilities to discuss their issues and barriers, and people can work together to find solutions, networking between facilities, and like I said, it holds the facilities accountable. Next slide. So second meeting, the focus is on sepsis screening and understand the sepsis screening audit process and then patient family education tools. So in the first meeting, we've asked them to complete steps 1 through 4 on the action plan, and we go over the screening tool, and we tell them to go and screen 10 patients so that they can understand how did it flow, what were their questions they might have. And the other steps is get a team together, get your medical director supportive and part of that team, and then begin to think about how you would put this screening process into your workflow, and how will you and how you put it in your workflow. So that's the round robin, and then on the sepsis action plan, we review patient education materials and then define the metrics to audit sepsis screening. And then the homework after the first meeting will, from the second meeting to the third, would be to develop and implement an education plan on sepsis screening and interventions for the staff, defining your go live date, and develop and implement a patient family education plan for sepsis, and define your audit process and collect an audit and we know you can't collect an audit until you've implemented, so that might not be able to be completed between meeting 2 and 3. So any questions so far? I don't see anything in chat. You can unmute and ask, or you can put it in chat. Okay, I'm going to continue. So I want to take a few minutes, just like I went over the screening process, I want to go over the audit process of the screening tool. And so this happens in the second meeting. What we're going to evaluate is if the screen is being done at the frequency that was defined. So remember, it's upon admission every shift for at least the first 7 days. And then we also want to evaluate if the screen is performed correctly. So not just if they did it, but did they do it right? And the other expectation in the auditing is to do a case reviews for patients who get transferred to the hospital for infection or sepsis. And I know that most facilities have a process in evaluating a transfer to the hospital to try and understand why. And so when you're reviewing a patient that got transferred to the hospital for infection or sepsis, you want to see if that patient was screened appropriately and did they get the appropriate treatment provided before going to the hospital. So go on to the next slide. So here's the audit process, and so you're provided, and in the toolkit is an Excel spreadsheet. Right, that's still what we're doing, Barb? Are you guys still collecting the data? And you send this Excel spreadsheet to them?
We are. So through the SNF portal, the criteria is if you've gone through the sessions, then you fill in those fields in the SNF portal. Yep. Okay.
So you have the ability, so we still have the Excel spreadsheet in the toolkit so that during the month, you can put your data in, and then, because you only have to put it in the portal once a quarter, right? And so Correct. Then you can take the information from the Excel spreadsheet to the portal.
Yep, you're right. So this is a nice tracking form for them to do along the way, and then they do it for the quarterly submission. They can take this and transfer it over there. Yeah, you're right, Pat.
Yep, and then they can give information back and feedback back to their teams and their staff that show how well they're doing. And it's important as you're doing this initially to give feedback, right? To look at to audit the data, to audit the process, and look at your data and say, we're not doing very well, and try and understand why. So those are the two measures, and so you can see that the first column is what the measure is. The measure name is identify residents screened for sepsis. The metric is number of residents screened for sepsis using the recommended tool, who's going to collect the measure, where you're going to get the data, and then your numerator and denominator. So the numerator is the number of residents that were screened for sepsis using the tool, and the denominator is the total number of residents in the facility. So the recommendation is you pick a day a month or a day a week. Initially, you want to do it weekly. Pick a day and collect data, audit half of the patients charts that are or patients that are in your facility, and then maybe the second day you audit the other half of the patients, so that you should get a decent sample of, so say you average 40 patients, do 20 one day, 20 the next, or you can do 20 1 week and 20 the next. But your numerator is the number of residents that were screened appropriately over the number of residents you audited. And then you want to make sure also that the screens are being done correctly. So you take a subset of those audits, so 10%. So say you did 30, take 3 of those and take a deeper dive and look to see if they were done correctly. So that would mean that the person doing this audit would screen the patient at, looking at the information that that staff person would have at that time, and then validate and compare it to the result of the screen that the staff member got. So hopefully that makes sense, because remember, it's did we screen them when we were supposed to, and then did we screen them correctly? And what people found to be very helpful was to take a different, each time they were auditing for screening correctly, they audited different nursing staff so that they could make sure that there was clear understanding with each of the staff. So go on to the next. So, and our process, we initially want you to collect the data weekly and give it back to, give that feedback back to your staff. And then once you monthly reach 90% compliance, then you can go to just doing it once a month. So initially, when you start a new process, you want to audit more frequently, and then you can relax that once you meet a good threshold. So your weekly sample size should reflect your average daily census. So those are the recommendations. Okay. And then, as Barb said, you would put it into the portal once a quarter. And the Excel spreadsheets have formulas in, so once you fill in the numerator and the denominator, it will calculate the percentage rate, and you'll know exact, and then it summarizes it for what you would put into the portal. So now we're on to meeting 3, and the goals for this meeting is they should have implemented sepsis screening by now and done at least one audit. And so you want to, the round robin is about having them share their screening audits and any questions that they had. If they haven't implemented the process yet, again, what are their plans for educating and their go live date and their patient and family. education. The learning session will talk about best practices for pneumonia prevention, and then how to perform a current state assessment on pneumonia prevention so you can identify gaps. And that's what the homework is. The homework is to complete that current state assessment. Okay, so that's meeting 3. Now we can move on to meeting 4. Well, no, here's the pneumonia current state assessment and action plan. So on the left-hand side, it's the current state assessment. The prevention practices, we review those in the, they're part of the PowerPoint, and so they're referenced, and they talk about good hand hygiene, oral care, swallow screens, proper positioning, mobility, and adequate nutrition as the prevention practices. And so the current state assessment is for each of these practices, do you have a policy in place that states you will do these? And then go audit 5 patients to see if you're compliant with those best practices. We also developed a specific action plan for each of the infection prevention conditions we were dealing with. So this is the pneumonia action plan, and there's one for UTI and CAUTI, and then for CLABSI. And so step 1 is agree upon the evidence-based practice to implement. So you do your current state assessment. You heard in the presentation the evidence-based practices you audited. You found out where your gap was in your not having all of the evidence into practice. You agree upon what evidence-based practice you want to implement. You had understand your current practice, you walk the process, you talk to staff, you collect the audits, you've identified the gap. You want to also identify barriers to implementing that new practice and strategies to resolve them, educate the staff on the new practice, implement the new practice, and then work on an auditing process yourself. And we're not going to have, you don't have to turn anything into MPro in the portal. This is for your own as you implement, and this is just good practice related to evidence-based practice implementation and process improvement, is that you always want to audit your new process. So one of the items that interventions that and practices that people found there were gaps in was related to oral care. And so they would put in the intervention. Maybe they didn't have the right tools for the staff, or the staff didn't realize the importance of oral care. And so they reset the expectations. They did some education. Maybe they got them different tools, and then they audited whether or not it was being done. And, you know, you define that yourself, but this is just good practice. And I know that in skilled nursing facilities, you now are expected to have a quality improvement program process in place. And so these are all the foundational framework for improving quality by implementing different evidence-based practices. Next slide. So the 4th meeting is we're going to review how it went with pneumonia and where your opportunity was and what your plans are. And then the learning session is related to preventing UTIs and CAUTIs. And then we also share a current state assessment on UTI and CAUTI prevention. And then it ends up with, on the action plan, your next step is to understand your current state for prevention practices for UTI and CAUTI. So go ahead, and I think I have so just like you saw with pneumonia, there's a current state assessment and action plan. So the assessment's on the left and the action plan is on the right, and you can see it's very similar to the pneumonia, at least the action plan is, the steps in the process that you need to do. But then in the UTI and CAUTI current state assessment, the prevention practices are different, right? So how do you prevent CAUTI and UTI? Those are the evidence-based practices similar to what you saw were the evidence-based practices in pneumonia. Okay, next slide. So program number 5 is, again, we're going to have round robin where we want people to share how the sepsis screening is going. If they hadn't reported on the pneumonia, report on the pneumonia, but then we want them to focus on reporting on their UTI current state assessment. Then the education we're going to provide, and we're going to provide them, is related to CLABSI prevention. And similarly to pneumonia and CAUTI, we're going to present the evidence, and then we're going to ask them to do a current state assessment and identify gaps. And then we will reinforce what the sepsis screening audit expectation is. Now, go ahead to the next slide. This will have the CLABSI current state assessment, and you can see that the action plan is the same with our other infection prevention strategies. So go ahead to the next slide. So you can choose to do a 6 meeting and bring people back and have, do a summary session, have them report out on their CLABSI information, their current state assessment, or you don't have to. So that's up to you. And that 6th meeting would really just be a summary, how, going through the sepsis screening, going through the audit, going through the 3 prevention strategies, and just making sure people didn't have any questions or how is it going. So meeting 6 is not necessary, but you could do it. So the coaching calls, just a little bit about those, and we found them to be very helpful. Sometimes people don't feel comfortable asking questions in a big group. People might feel more comfortable putting something into the chat, and so that, you might have more open dialogue there. But the purpose of the coaching calls was to be able to provide individual support to each facility to ensure understanding of the content that was presented and the homework. So the calls would typically take 15 minutes. You would talk to the facility rep that attended the meeting. You would review the homework and ensure understanding, and have them share any barriers they might be having and answer their questions. So it's a brief call, but it's a nice touch base to make sure that you don't want them to come to the next meeting saying, well, I didn't really understand what I was supposed to do, or I couldn't do it because of this. So it, as they're getting into this, it was often helpful because you could clarify things. Okay, next slide. And so we also, I think, as Barb talked about earlier, we did something similar after our collaboratives with the skilled nursing facilities. We also worked with home care agencies and had a similar program. We know out in the literature, or out in the public domain, the Home Care Association of New York did a sepsis program with their home care. We looked at their content but kind of modeled it after what we had done with the SNFs and Barb has that information available as well. All right, so that's a lot of information that I went through. So there's the home care screening tool. So to go on to the next slide, and we zipped through this faster than I expected, but now I want you guys to talk. And maybe we can bring up the toolkit on the screen, and then we can walk through that if there are other questions. So what questions do you have? And I might just call on people, because this is supposed to help you, okay? From what I just shared with you, what questions do you have? Do you have any questions specific to content of one of the components, one of the sessions, sessions 1, 2, 3, 4, or 5? What other information would be helpful for you in order to be able to do this successfully?
Hi, Pat. This is Dolly. Can you hear me from St. Mary's
Yep.
in Livonia? Hi. So I
Hi.
have a quick question. I'm the sepsis coordinator for the hospital, and I'm being introduced to MPRO like literally right now.
Okay.
How do you suggest I go about, because from my understanding, we have agreements with neighboring, I'm new to the hospital. From my understanding, we
Okay.
have agreements with neighboring nursing facilities, skilled nursing facilities. How do I go about basically implementing this there? Because I don't have access to like medical records so that I can do audits. I'm just gonna teach them to do this, and then they have to provide the answers
Do it
to
themselves.
me? Okay. Okay.
Well, yeah, and so Belinda, you're on the line, right? So this is St. Mary's in Livonia, right?
Yes, that is correct.
So Belinda, is there still a venue where we're meeting with the SNFs?
Hi, I'm sorry, I was on mute. Hi, Pat. How are you?
Hi, Belinda. I'm
Hi,
good.
Belinda.
Miss you.
Hi, Dolly. How are you?
Not bad.
Yes,
How are you?
participation in sepsis initiative and data submission to MPRO once you complete the training is still a requirement for high performing status.
And they still have
So-
the SNF coalition meetings where they get together too.
Yes.
Yes. Mhm.
Okay, so then Belinda,
So-
you can like walk me through what
Yes.
the
Sure.
expectations
What
from
organizations
me
have
is.
been through? Yeah.
Yeah. Okay. Okay.
Absolutely.
Perfect.
Yes.
Perfect.
Mhm.
Thank you so much. Thank you.
You're welcome.
And then you might be able to, you know, Belinda will be able to, and you should have access to the MPRO data when they submit their screening information to MPRO quarterly. You should be able to pull that data, and then you might not need to do a full training program because most of the St. Mary's facilities were trained, but you can see who's maybe missing data or performing low and reach out and maybe there's a group of them that are not performing that well, and then do a refresher and bring them back in. Because we know that at skilled nursing facilities, the leadership often changes, and if they hadn't really ingrained this screening process and it had not been hardwired yet, it probably went by the wayside. And the new leaders might not even know.
Okay. Okay. Well, we'll pick it up and take a look and see what information is out there and then move from there. Thank you so much for all the feedback. Thank you.
You're welcome. Other questions?
It looks like we have a question in the chat.
Okay.
How often do you recommend facilities offer refresher training for current staff previously trained?
So the facilities themselves, you can judge that by your compliance, right? So if your screening compliance, when you're doing your audits, Holly, when you're doing your audits, if you're finding that you're seeing your compliance is less than 90%, or you have a fair amount that are not screening correctly, then you would target your education to to either a group of staff that weren't doing it correctly, or just refresh the whole team at, you know, a staff meeting. Maybe you have them listen to some of the videos again that are already pre-recorded. So again, if you put this into your onboarding, and Holly, do you know if this has been put into your onboarding?
Hi, Pat, this is Holly. I'm actually from MPro, so.
Oh, okay.
Yeah.
All right. Oh, okay. So
Thanks.
you would want to have it in your onboarding, and then use your data, and that's what the data is there for, to identify if you're having an issue. What you might also do is, if you're finding, you know, so your data is coming from your audit data, but remember we talked about reviewing cases that had to go back to the hospital for infection or sepsis. If you're finding that you're noticing that when patients have to go back to the hospital for infection, but we know sepsis patients are more likely to get infected again because that's part of this post-sepsis syndrome. So before that patient went back, were we screening them? Did we recognize them appropriately? And did we intervene appropriately? Because that's where you're going to find where your gaps might be. So maybe we're screening, but when we call the provider, they don't want to do anything. And we've called the provider a couple times and they say, no, let's just monitor them. You know, so then that's might be where your gap is. And so then that's when you lean back on your medical director, you review the case with them, and you talk about, okay, so is it knowledge? Is it confidence in the staff at the facility being able to provide fluid and IV antibiotics? So you use the data that you're collecting, both the audit data and then the reviews of patients that had to go to the hospital, to drive where you need to have additional training, or where you need to tweak your process, or do some more education, or hold someone accountable.
Thank you.
Hi, Pat. This is Tanya Cook from Signify Health. Can you guys hear me?
Yep.
Okay, awesome. We actually work with 3 of the hospital systems in the area, the Trinity, Ascension, and Beaumont systems, and several of SNF providers on kind of the management of the BPCI, or bundled payment patient population. And yep. Barb and the rest of the MPro team has been so gracious about letting us participate in the conversations and the feedback surrounding your sepsis monitoring protocol, because we do have kind of similarly aligned objectives of reducing those transfers back to the acute setting. And as one of the topping points that a couple of the SNF providers had kind of relayed as first line anecdotes as to what was happening as we implemented this, they were finding that despite the fact that they felt like there was an early recognition of potential sepsis, that when they did speak to the medical directors, they did choose a kind of more conservative approach to potentially transfer them to the ER and to not do any antibiotic course in the SNF. And so question about that is, I guess, twofold. One, do you have or recommend any provider level education that we could use to increase buy-in of those rounding physicians and advanced practitioners? And 2, have you seen historically that starting antibiotics has been a barrier, and do you have any suggestions for overcoming that?
So I hear 2 questions. So provider education is key. And so you want to be able to provide appropriate education to the provider. And that education would be similar to what's in meeting 1, but with an emphasis on fluids. And I think that So go into, we updated based on feedback, and this was one of the feedbacks, giving some more information about the importance of early antibiotics and fluid. So Barb, could you click on the PowerPoint for session 1 from the toolkit? Because I think we went back and added some evidence-based studies related to, fluid and antibiotics. And this is where the medical director is important to have on board, and so that they can reinforce with all of the providers from that institution that this is an expectation. But you have to find out, once they're provided with this information, you need to find out what is their concern, right? And often they don't feel confident that the staff can handle it, right? And so that starting with that SBAR, and when you're calling that, yes, we have this available. And as you're starting the program, the medical director communicating with all of the providers that this is what we're putting in place, and we the facility has the ability to do IV antibiotics, and that medical director needs to have those conversations with the providers to understand their concerns. So just scroll down there, Barb, and let's see if it's in here. Keep going. It's going to be in the content section. So go ahead, keep going, keep going, keep going. Keep going. Okay, keep going. Okay, keep going. Keep going. Yep, here it is. So starting on slide 38, we put in, I mean, the other slides are important too with just some factual evidence, but this, so go up to slide 37. And maybe even slide 36. I don't know what's on slide 36. Yeah, so here from 36 on, we talk about the importance of early antibiotics and fluids in patients with severe sepsis. And so it tries to answer some of the questions and concerns that the providers might have related to, I don't want to give this old person fluid, you know, their end-stage renal or their heart failure, history of heart failure. This talks about why they need fluid. And then the slide 38 is, you know, if you only give 250 cc's, that, you know, 1 liter is only going to add 275 cc's to their volume. Don't fear the fluid. And then there's studies that from slide 40 on that talk about the importance of fluids and early antibiotics and evidence-based that it's not going to hurt them. So here, the timing of early antibiotics every hour between presentation and antibiotic administration is increased, associated with a 9% increase in odds of mortality. So if I'm going to watch them or send them to the hospital, that's going to at least take a couple hours. And then for them to the hospital to work them up, again, it's going to take them a little bit of time. So, and then by early antibiotics, I'm going to more likely prevent the progression to septic shock. So, and then the next 2 slides are about fluids. So, Tanya, was that helpful? Tanya, we can't hear you. Did you unmute? You're still muted, Tanya. All right, I'm trying to remember also her second question. So it was providers wanting to send them to the hospital to give antibiotics and fluids. And what was the second part of the question? So Tanya, we still can't hear you if you're talking. Sorry, it won't let me unmute.
Yep.
So then write in chat, did I answer your first question? We can just go by chat if it's not going to let you unmute. Because you look unmuted.
Let's see. I think we were able to unmute you manually, Tanya. Can you try saying something? No, still didn't work. Yeah, so maybe if you can just write it into chat. Sorry about that.
Okay, so yes to the first question, okay. So it's really about finding where the barrier is from the providers, and that's the medical director, or beginning with the medical director. Is the medical director the barrier? But you should have found that up front as you started the program because they needed to be there as part of it. Takeaway is medical director buy-in early. Yep. And that's why it's number 2 on the action plan. What was your second question, Tanya? You can write it into the chat.
Let's see. Yes to the first question, and takeaway is medical director buy-in early, specific to the IV. Yeah.
Okay. And so hopefully some of the, all of the evidence related to antibiotics in severe sepsis and septic shock are IV antibiotics. So they need to be broad spectrum IV antibiotics. So was that the question? And then the articles there showed the importance of giving early antibiotics. So Tanya, was there another question related to IV antibiotics? Or did that answer? And then,
Linda
I heard
Jackson.
you say the medical directors to the rounding physicians on dispelling the IV fluid education, right? And the same with IV antibiotics. You need to have IV antibiotics, and especially if the patient's not hypotensive and so doesn't need IV fluids. Wow, you can really start the IV antibiotics and prevent them from progressing. And then someone asked, will this slideshow be available for us? Now, which slideshow? The one that you're seeing right now is available. It's part of the toolkit. It's session 1. Those were the things that we wanted you to review prior to coming today so you could ask questions if you had questions about the content of each of those. Let me know, but Barb will make today's slideshow.
Yeah, we certainly can send that out to all the attendees, as well as, yes, earlier in the chat, this slideshow along with the whole toolkit, that link was put in there, and yes, and we can make your slides from today's presentation available.
Okay. So Belinda, you had a question?
Mm-hmm.
Hi, yes, I do. I wasn't sure if you want me to put it in a chat or ask, but so Dahlia and I have been working there. We are both on our sepsis initiative at St. Mary's, and we are working on a document. And I thought, Pat, maybe you developed something already that is more appropriate for a patient to share, how to recognize signs and symptoms. And primarily, we wanted to implement that on the inpatient side when patient is discharged, but also can work for skilled nursing facilities as well. So have you developed anything like that that is more like patient specific?
Yep. So go down the toolkit. There's a couple things. It's under patient education, so I think it's under the tools section. Keep going, keep going. Here, patient education, right here.
Okay. I'll take a look.
So
Thank
these
you.
are tools, but there's also another one. So click on the signs of infection and sepsis at home. Yeah.
Great.
So
That?
this one, yeah.
Oh, very good. Thank you, Pat. Thank you for sharing.
You are welcome. And you could easily give this to patients when they're leaving the hospital. And it has a nice second page. My plan for preventing infection at home is,
And this is great for even COVID. So,
oh yeah, yeah. Yeah, so it's interactive and, you know, it shows you when to get concerned, yeah.
Thank you.
You're welcome. So I'm wondering if it might be helpful to, if there aren't more questions, to kind of walk through this toolkit, to go back out, and just make sure people understand what's available in the toolkit. So any more questions, and then we'll just walk through the toolkit a little bit, pull up some of this stuff and so you can see it. Yes, please do the walkthrough. Okay. All right. So we have training materials and then we have tools. So let's go through the training materials. So this is just an overview and what to do. So here's the participation agreement. Why don't you open that up, Barb, because we didn't get a chance. And this is more if you're a hospital and you want to partner with different facilities, having them sign this agreement so that they're clear on the expectations is something that's helpful. So here, and this is something that when MPRO was helping facilitate doing these, and we were doing them, you know, twice a year, we would send this out to facilities to see if they were interested. And you can see it outlines what the program's about, the facility expectations, and what can you gain from joining this program. And then you can see at the bottom that you have the medical director or the nursing home administrator sign it so that they understand the expectations and they can help, you know, support the team through. Okay, so go ahead and go back. Question for Barb at MPRO. Are most SNFs who participated in the program providing their data through the portal?
Can you guys see the toolkit again?
yeah, we can still see the, well, no, we're
Okay,
No, we see the
on the
participation guide
agreement.
still.
Yeah.
gotcha.
So,
Thank you.
yes, I would say that, let me see, was the question again that if they've gone through the training, yes, the majority of them are submitting data through the portal. And so for the skilled nursing facilities, they all, once they go through the training, they all submit their data through our portal. It's not to confuse the issue, but for the home health agencies, they just submit it through a spreadsheet, and then our analyst takes it and analyzes it and puts it into an analysis form. But for the skilled nursing facilities, we were able to get that into the portal. So if you're talking to a home health agency, they have a different process. So I don't want to confuse that, which I probably already did, but the skilled nursing facilities all have access to the portal and put that data in there, yes.
And so I think her question was, so do you know offhand,
Yeah.
Barb, is it 90% or 80%
Yes.
that are submitting on a regular basis?
Yeah, so who, of the ones that have completed the SNF training, yes, I would say there's very close to 95 to 100% compliance with putting that data into the portal. Yeah.
Great. That's
Mhm.
awesome.
Mm-hmm.
Now, the data might not be great, but it's there,
No.
right?
Exactly.
Oh.
Yes.
And that's where, if you know facilities have gone through the training, and if you're not aware of who's gone through the training of facilities you work with, MPRO will know.
Yeah.
I
Mhm.
used to have those lists. I mean, I probably still could find them, but Barb can
No,
probably find
yeah.
them sooner.
That's right. We have the up-to-date list of all those people. Yep.
Oh, Linda Jackson, I have a question for Wormwood. Monthly submission, are we doing this like at the beginning of the month or the end of the month? For baseline monthly submission, if we're doing facility expectations.
So it's collecting data monthly and any day of the month, but submitting it and then putting it on your own Excel spreadsheet, and then you only have to put it into the portal quarterly.
Oh, okay. Thank you.
So, but you'll want to collect it. You can't wait for the end of the quarter and then just collect it, because you need to have data from each month. So they're just not expecting you to put it into the portal monthly. You can if you want, but
Well, actually, they can't. We don't have it open like that. Sorry, Pat. It's only open quarterly, so they can only put it in quarterly.
Okay, good.
Sorry.
Thanks for that clarification.
Good.
You have, and we'll open up that Excel spreadsheet as we walk through this toolkit, so you can see where you can open it and record your data monthly, so that you have it ready to go into the portal.
Okay, thank you.
So we'll continue down. If other people have questions, please ask. You saw the action plan and the agenda in the PowerPoint already, so I'm not going to. Presentation slide for meeting 1, that was the one we had brought up. That's the one that has heavy content in it. It's about sepsis and management of sepsis, screening for sepsis, why sepsis is important, and it has all of those references of studies that show the importance of fluids and antibiotics. Okay, so meeting number 2. So if you, let's bring up the data collection tool, sepsis process measure data collection tool. So this should be the Excel spreadsheet, Jessica, I think, if you're bringing it up.
Oh, I see it, yes.
Okay, sorry, just trying to get it a little bit bigger here.
Yeah, a little bit.
All right, so that's the first tab. So the first tab on the Excel spreadsheet is direction, right? Do this, then do this, then do that. So it's kind of just informational. So then if you go to the next tab.
One moment, please.
And Jessica, I'm correct, it's an Excel spreadsheet, right?
For some reason it's coming up as a Word doc, as a PDF for me.
Yeah, in the toolkit, I think it is that way, but we provide that to everybody as an Excel spreadsheet that populates it on its own. So yeah, if they needed that, I thought we had it that way in the toolkit too.
Yeah, you know,
so we'll check on that.
The Excel spreadsheet in the toolkit, because then it has the formulas in it, and if I've misplaced mine, then I can just go back to the toolkit. which is
here
the
we
beauty
go.
of this toolkit.
Where'd my, one sec, I lost my little bar here to share this with you guys. Sorry about that.
That's okay. So as she's looking for it, I just kind of want to ask a general question. Has this been helpful? Do you feel like you are ready and could provide this and facilitate this education?
Here we go.
And you can answer in the chat if you want. Okay, perfect. So this is an example of, so here's January, and the first measure is sepsis screening compliance rate. And so the numerator is the number of residents with 2 or more completed screens in 24 hours. And the denominator is residents eligible for sepsis screening. So say in week 1, and can you fill in numbers for me, Jessica, when I say them so they can see how it calculates? So
No.
No?
I think,
Because this is still the Word?
yeah, because it's still a read-only version. I'm sorry.
Okay, that's all right. So if I put in 5 over 10, you know, so my numerator was 5 and my denominator was 10, that would be a 50% compliance, and I put that in, and it would automatically fill that in under January data to enter into the portal. It would fill in the numerator and denominator and give me a monthly compliance. And then as I put in week 2 and week 3 and week 4, it would add it all together so that at the end of the quarter, then I can just go to each of these and enter them into the portal. So it just makes it very easy for you to collect data throughout the month, and then it summarizes it, and then you move on to February and do the same, and then March, and then when it's due for the portal, you pull up the 3 months that go into the portal, and month by month, and you put that data in, and it's right here. This is the data that's going to be expected to be put into the portal. Any questions on the data? And this is one of the topics that I often use for the coaching call. So we would, you know, I would ask them specific questions that they might have in collecting the data, what their process was, who was doing it, and how that was working. Okay, you can go back to the toolkit. Thank you, Jessica, for navigating.
You're welcome.
Okay, so that's meeting 2. So meeting
And I think
3, why don't we
Tanya
bring,
has another question here.
what
So
readmission?
she's,
No,
yeah.
yeah. So we've not linked the readmissions because when they're doing the audits, they're not collecting specific patient information related to those audits. It's just 5 audits or 10 audits. And so there's no way to link back, at least with the data, and people are then not putting, you know, HPI data into the portal. So I appreciate all the questions, Tanya, so keep them going.
Yes.
And that's why.
And yes. And now we have been able to do some comparison with our claims data to see if the targeted skilled nursing facilities, you know, if it's kind of like aggregate, has sepsis readmission rates been trending down, but we know that's not apples to apples, but at least it is some things that we've been able to do through the Medicare fees claims data that we receive to kind of compare how the program's working. But it, you know, It's just a little bit more global.
Right. And then have you guys looked at a facility compared their screening compliance data with the readmission as well? So yes, they put in the program, but if they're consistently 90% compliance, do those facilities have less readmissions? I'm just throwing it out there.
Yeah, we haven't done that specific or targeted look yet. We tend to do, again, more aggregate, like we'd see of the SNFs who've gone through the program, you know, did the rate go down, that kind of thing.
With that data, we have seen readmission rates go down and mortality.
Yeah, correct.
At least from the initial analysis that we've done. Now, one of the things, even though it's not included in information that you would put into the portal, we recommend that when, again, I sound like a broken record, if you're reviewing a case of a patient that went back to the hospital, how you're going to know whether or not that readmission, you did all that you should, is to review that case to make sure that screening was done and interventions were appropriate after the patient screened. So even though we're not specifically linking, part of your case reviews should include looking for those patients that have been readmitted to the hospital, and did we do the appropriate interventions based on this sepsis work. Okay, so moving down, so pull up the infection prevention pneumonia one, and we'll just look at what some of the content looks like and see if anybody had any questions related to the pneumonia content.
Can you guys see that?
No, I can't. We still see the toolkit.
Okay, thank you. One sec. How about now?
Yep.
Okay, thank you.
Okay, so go to slide 4. So slide 4 says, what did we do at the last meeting? And so it reviews what we did at meeting 3. And then the slide 5 talks about the agenda for today, and it's the round robin. And in this presentation, in effect, we probably need to change this slide, Barb, as I'm thinking about it, because we initially, with feedback, put in the importance of antibiotics and fluids here, but then we added it to the first lecture, so we can probably take it off here if it's still here. Do you know what I mean?
Oh, yep, we can do that.
And so if you go to slide 7, we start talking about pneumonia, and then the next slides are the evidence-based practices. So you see pneumonia statistics, and then what is pneumonia, and then risk factors for pneumonia, why older adults are at higher risk, and then it talks about the different risk factors and how pneumonias happen. These are the predictors of aspiration pneumonia, and then 16 and 17 talk about that germs in the mouth get aspirated into the lungs, and if people have weak defenses, then they're more likely to get into the lungs. And so what do you do about that? And the interventions are comprehensive oral care, preventing aspiration in the lung, that's the swallow screens, tube feeding protocol, head of the bed up, and weak defenses. Those are the 4 interventions. And then it just walks through a little bit more detail of those interventions. So the next slides are why the mouth is full of bugs, and why you need to clean the mouth. And then it gives some of the evidence on oral care and skilled nursing facilities and what practices not to use. So slide 23, we should not have lemon glycerin swabs. And then a couple more studies in 24 and 25, and 26, brushing, how important brushing is. And then 28 is what oral care should look like, whether you're independent or dependent. And 29 is actual oral care protocol. And then 30 is just, you know, hand hygiene is the foundation of preventing infection. And then this outlines all of the strategies. And then we have our pneumonia action plan and the homework. So that's the content for the pneumonia one. And so the other ones are set up similarly, both the UTI, CAUTI, and then the CLABSI one. So when we go back to the toolkit and walk through a couple other things, and then if there aren't other questions, we can give you an extra, 15 minutes to your day. So you see the next ones are the presentations 4, 5, and meeting number 6, again, is the summary meeting. If you want to have it, you can have it. Again, it's just bringing it all together. And then we move into tools. So here's the educational videos that we were talking about that I had mentioned. There's the what is sepsis for the CNA, because it's important to educate the nursing assistants. And then there's 2 20-minute videos for the nurse. What is sepsis, and then early identification and management of sepsis. So both of those are nurse, part 1 and part 2. So the what is sepsis goes over the pathophysiology, and then the early identification and management goes over the screening tool, and then the what's the bundle. Next, you see the different current state assessments, and for pneumonia, UTI, CAUTI, and CLABSI, and then following those are videos. So what the facilities can do is, if they, you can either supplement education, so you can either use the PowerPoint slides and present content yourself on best practices for pneumonia prevention and CLABSI prevention, et cetera, or you can have the staff watch these videos. So there's one for pneumonia prevention, preventing CAUTI and UTIs, and then preventing CLABSI. And then there's an evaluation tool. And that's just an evaluation of the program. So then the next section of the toolkit are just the different tools, right? So we showed you the screening tool already. The screening algorithm is just placing that screening tool into a algorithmic format. And then the bundle we showed you on a slide, and the stop and watch we showed you on a slide. And then we linked these already when someone had a question about patient and family education. So you can see that most of these we did not create. They're reference from Sepsis Alliance or other places. I think that's the end to it. Is there anything else on the, so then resources. So these are always great resources to have. So links to where you'll find even more information. So that's it in a nutshell.
So last chance, any other questions for Pat today? We'll give it just a minute. Again, let's see. Oh, and we do have an evaluation for today's presentation. It's always very helpful for us to see if this was helpful. I'm sure Pat would like the feedback. If there was anything you had a question afterwards or anything like that, you can also do it in the evaluation and we'll get that information to Pat and get your questions answered. So this has been in the chat, but it was in the invitation. The whole sepsis toolkit is there. Yeah, some of our timelines just keep getting adjusted for our implementation and such. But we did want to have this train the trainer now. We are thinking that it would be more in the fall or early spring that we would be working through as a region, providing the training for the skilled nursing facilities and implementing it on a wider spread. But we did want to have the ability to train some people today to get this sort of in place and up and running. So the logistics will follow up with Pat after that to see, if she's available to do some of those coaching calls for actually the trainers once you start implementing. But it will be a little bit farther off than we initially anticipated. From today's, we certainly will be able to provide a certificate of completion for everyone. We will take a look at the participation list and be able to get that out to you. If you don't receive it, say in a few weeks, please let us know and we'll circle back and get that for you too. Any other questions at this point? Looks like most people are saying thank you, no questions. It was wonderful. Yep.
Well, that's great. Thanks for the feedback, and I'm glad this was helpful. And again, once you get into it, you might have more questions as you're doing it, and that's why I think, as Barb said, we'll try and put some time together where we can chat after you've started and you've had a session or so. But I want to thank everyone. Sepsis continues to be near and dear to my heart, and it's so important to recognize early, and we do have the tools at skilled nursing facilities to do this and to give early interventions so they don't have to go back to the hospital, and so that if they do go back to the hospital, they're not as sick because we've identified it and intervened early. So I want to thank everyone for their time today, and go out and save lives.
Yeah. Thank you, Pat. And we feel the same way for you, that we appreciate you being so dedicated and continuing to put this forward, because it's incredibly important, I think, especially during this time too. So thanks so much. And thank you everyone for attending today. Let us know if you have any other questions and we'll help you out. So thanks so much.
Thank you.
All right.
Bye-bye.
Bye-bye.